The first thing I would like to say is, bone marrow transplant really should be considered as a part in the patient journey. So we should not consider transplant as something different from, the whole process, the whole journey of a patient with acute myeloid leukemia, who starts, of course, with induction, consolidation, then also transplant comes in. And so when we consider a transplant, we should really consider, on one side, the biology of the disease, how aggressive it is, and also the history of the patient, which chemotherapy received, which consolidation therapy received, which comorbidities he has before the leukemia story, and also that were accumulated during the disease. And finally, and very importantly, also the MRD results, the results that we get with the treatment. And according to all of this, then we can decide if we can offer and if we can allocate a patient to transplant. Again, considering on one side the biology of the disease and also the condition of the patient, the comorbidities. And so we really need to make, trying to understand the pros and cons of such a complicated procedure when we are offering to our patient, keeping in mind that more or less we are reducing by 50% the risk of relapse when we transplant a patient with acute myeloid leukemia. And again, keeping in mind all of this information, we can decide a transplant which is customized on a specific patient, on a specific disease, and this is how we can get better results. And with this I mean choosing a conditioning chemotherapy, which can be myeloablative or reduced intensity conditioning, or again we can use different GvHD prophylaxis, and even more importantly, according to the disorder, to the biology of the disease, we should consider how quickly to taper the immunosuppressant after transplant, because as easy as this is, but this is a very relevant therapeutical act that we can use to get better results in terms of graft-versus-leukemia. And then again, considering the fact that the transplant should not be considered anymore as the last bit and the last therapy for our patients, there are all different approaches that we can use in order to ameliorate and have better results after transplant. So on one side, we can do many things in order to facilitate and somehow quicken the graft-versus-leukemia effect. And we can do this, again, reducing and tapering a bit quicker the immunosuppressive agent, or also using DLI or all different lymphocytes that can be used again to facilitate graft-versus-leukemia. And as we heard again in this nice meeting here, there's new space now for maintenance therapy, and there's a lot of new therapeutical agents, for sure, FLT3 inhibitors, TKI for acute lymphoblastic leukemia, and there are new data and new trials using oral azacitidine for maintenance after transplant, also menin inhibitor such as enzomenib after transplant. So again, the field is expanding, and I really think that we should work more and more, transplant physician, hematologist, leukemia expert, in order to understand how to better treat our patients.